Hey everyone, so welcome to Orion's Peachy, and today we'll be discussing about dysphagia, swallowing therapy, and what are the most common compensatory therapy techniques that we use for patients with dysphagia. I'm Shruti Satyan and I'm a medical speech language and swallowing pathologist who's working in Kochi. So compensatory swallowing techniques are techniques that are temporary, which can actually make you swallow better, but it does not help in strengthening the muscles. And we can also have food while doing these techniques. So it's a direct form of therapy. Now, there are 4 ways. One is postural modification, another is diet modification, and the third one is sensory enhancement, and the final one is some sort of behavioral approach that can help in a better swallow. So the first one is chin tuck, that is like this, and then there is chin down, that is like this. Now this will help in closing the anterior pharyngeal wall back so that the tongue and the epiglottis will go back to the pharyngeal wall and close. And this can help in narrowing the airway and also giving better protection against any sort of aspiration or penetration. And when all these structures are in approximation, this will also help in widening the valvulae, so a better pharyngeal swallow will be triggered. And this is known as chin tuck and chin down. We can do both these things together. The second one is head turn. Usually we do the head turn to the weaker area. So maybe if you have got a lot of pulling and the structures are not moving properly, or the vocal fold is not closing properly on one side, then you can turn your head to that side and swallow. So this can help the bolus to flow through the normal side. Now the third one is head tilt, and head tilt must be done to the stronger side. So when you tilt your head like this, through the stronger side the bolus will drain down to the foot pipe. And sometimes you can even tilt your head and also lean your body to that side a bit for a better swallow. And another one is you can lie on the stronger side, so you can propel the bolus through the stronger side for an easy swallow. And the fourth one is head back. So the gravity will do all the action and the bolus will be pushed from oral cavity to the pharyngeal cavity with ease. And this is mostly done in cases of glossectomy where they can't move the tongue and the tongue propulsion and bolus formation is very poor. Now next, moving on to the diet modification, you can modify the texture, you can modify the volume of the bolus, and you can also modify the temperature of the food items. If the patient is having too much residue in the oral cavity, then you can go for a thinner form of diet. But if the patient is having the risk of aspiration and penetration, then you might have to thicken up the diet. For poor tongue-based retraction and also poor laryngeal elevation, there will be a definite residue in the oral cavity. So for this reason, you might have to change the texture of the food item. You can also modify the volume of the bolus. Some patient tends to have a better swallow when they are having a small bolus. But in some patients, especially in patients with dementia, we have observed that the patient, when you are given them a bigger bolus, they know that something is there in the mouth, and then there is a better tendency for them to swallow better. And the next one is sensory enhancement. This can be done with taste and also temperature. Taste, you can use lemon or orange juice, and for temperature you can use hot water, which is tolerable for the patient, and also ice. So this is known as thermotactile stimulation, and here what you can do is take 1 cup of hot water and another cup of full ice, and then you can put different spoons in both of them. One spoon becomes really hot and the other one becomes really cold. Now you can take each of these spoons alternatively, and using the spoon you can massage inside the patient's mouth onto the anterior facial pillars, base of the tongue, and sometimes even the cheek. This can improve oral sensation and also trigger a better swallow reflex. Now another approach is jet feeding or posterior placement, that is, we take in the bolus in a syringe or even in a small spoon and place it on the back of tongue. So the patients with glossectomy mostly have this difficulty, and they have difficulty in tongue propulsion and bringing the bolus back to the pharyngeal area. So this is more convenient for them. So these are the main things we need to do. One is posture modification, another is you can modify the diet, the temperature, the taste and texture and even volume of the bolus. Then you can do some sensory stimulation, and apart from all this, there are small simple tips that you can follow. One of the main thing that you have to follow is don't ask the patient to just gulp down water if there is any sort of dysphagia. Instead, ask them to take small sips of water, and even while they're taking food, let them take small bites of food instead of a large chunk. Once the food is in the mouth and the first swallow have occurred, they can even practice sequential multiple swallow, that is, so this can clear any sort of residue that is left in the valvular or piriform sinus areas. And in some patients you can observe there will be a mild pooling of residue, maybe for the blended diet or soft solid diet or even solid diets, that it won't just leave even if they swallow a lot and lot. So for this one, you can give them a liquid flush, that is, after having 2-3 bites of food, they can just have a bit of water, drink with multiple swallows. But this must be done only cases where there is no aspiration or penetration for liquids, and this must be done under supervision. That's all about swallowing therapy and simple compensatory strategies that might benefit all your patients. And hope you like the video, and get back to me for what's the next thing we can learn together. Bye-bye. Honestly guys, when I started working, I really noticed that I have so many dogs in here. I have so many dogs in my nearby house, they just don't stop barking at night. My god. Really guys, this is the time? Honestly guys, when I started working, I had no idea how to use these techniques properly on a patient. I just knew the theory part, and I have never seen swallowing patients much in my life. But what actually helped me was when I started doing VFSs, I used to try all these techniques on most of the patient. So I know what way the bolus will be going and what's going to happen next. And this is how I got a better insight on how each swallowing techniques helps the patient in different manners. One thing which I have realized is when we do the head turn and head tilt technique, which is theoretically told to be done head turn to the weaker side and head tilt to the stronger side, but in some patients I have observed the reverse can also work. So you have to try for different patients, different therapy techniques might work and might not work. You have to confirm it properly, and I prefer VFSs for that, because in cases of fees, most of the patients are uncomfortable with the endoscopy inside, but during VFSs everybody is quite free to do the techniques. Still, there is a lot of radiation during VFSs, so you have to try doing all these techniques in a really fast manner, but also considering the patient's cognitive level and the patient's physical activity level. You might have to wait a while for the patient to adjust. So all the best. It's all learned with practice and with a good knowledge.